I wanted to start with a short introduction, but I'm sure you're all familiar with it. And so basically, FSHD, as you all know, is quite frequent, is the third most frequent muscular dystrophy. It has an annual incidence rate of about 1 over 10,000 people and affecting approximately 800 people worldwide. As you all know, it's a genetic disease with an autosomal dominant transmission. There is approximately 10% of the mutation that are de novo, and interestingly, 20% of genetically affected people will actually be asymptomatic, and that's the concept of incomplete penetrance. There is a normal life expectancy, but of course, you all know the disease. It can create some significant physical disabilities and reduction of quality of life. And the main unmet need at this moment is probably the lack of disease-modifying treatment. And that's why it's so exciting to talk about this possible new medication entering in the landscape of FSHD. But before that, I wanted to remind you a little bit about the pathogenesis of FSHD to understand clearly what is EP 321 supposed to do. And so for the pathogenesis, we need to go back at the beginning, and everything starts at the chromosome 4 and at the end tail of the chromosome, where you can see the zoom in part. I don't know whether you see my mouse here, but here there is a region with D4Z4 repetition, and actually the DUX4 gene is also located in this part. And the DUX4 gene is quite important early in life, where it's briefly expressed to stimulate other genes to produce protein that will be really important for cell division, so at the embryonic stage. And then it will be shut down for the rest of the life of the patient. But unfortunately, in FSHD, this DUX4 gene is re-expressed, and when it's re-expressed, it's quite toxic for the muscle cells predominantly, with different pathways that are activated, such as cell death induction, RNA decay, RNA processing alteration, and also the alteration of the immune response, etc. So how is this gene normally repressed or controlled in a normal individual? Well, basically, there are three main mechanisms, three lockers, if you want. The first one is the number of D4Z4 repeats. The second one, which is quite important, is the methylation rate. And the methylation, basically, it's a process where a methyl group is added to the DNA strand to protect it in some ways, to create a wall that will prevent other protein to come and to express the gene into a protein that will then lead to the consequences I just showed you. And the third mechanism is the presence or not of polyadenylation signal. And when this polyadenylation signal is present, it will stabilize actually the mRNA transcript coming from the gene and allow the disease to be eventually present if it's combined with a reduction number of D4Z4 or a low rate of methylation. And actually, there are two versions possible of this subtelomeric part here. Either you have the 4QA version or the 4QB version. And only the people with the 4QA version have the polyadenylation signal. So all the people having the 4QB version of the subtelomeric part won't develop the disease because the mRNA transcript cannot be stabilized. So it might be a bit oversimplified, but that's basically the mechanism involved. And to summarize that into the FSHD pathogenesis, well, we can say that in normal people, there are two possible situations. The first one is when you have a normal number of D4Z4 repeats, which are usually between 11 and 100, with a normal rate of methylation. That's the yellow blocks here. And either you have the polyadenylation signal or not, it doesn't matter, you don't develop the disease. However, if there is a reduction of the number of repetition, a reduction of the methylation rate, but you have the non-permissive allele, so the 4QB, as I said, you don't have the polyadenylation signal, which is really important to stabilize the mRNA transcript, so you won't either develop the disease. On the other side, if you have a reduction of the number of repeats between 1 and 7 and a low methylation rate, you will develop the disease. If you have an intermediate number of repeats and an intermediate rate of methylation and the permissive allele, then you will either be quite mildly affected or asymptomatic. And finally, there is the specific case or FSHD2, which is basically with a number of repeat that is quite normal, but actually the mutation is here in the maintaining system of methylation, and that will also lead to symptoms, but it's FSHD2, and we are not going to talk about this typical form of disease because the medication we are talking about was not primarily designed for this disease as of yet. So now that we know a little bit more about the pathogenesis of FSHD, how can we act on this disease? How can we possibly treat this disease? Well, basically, we can try to act at the genetic level, and that's what gene therapy can do. So in terms of gene therapy, it's basically to treat or prevent disease by acting to the genetic material of the patient directly. So there are different kinds of gene therapy. Either you add a gene that is missing, so that's gene addition, or you edit a gene that is mutated, that's gene editing. And finally, there is also the possibility to silence or to modulate a gene that is mainly too active. And that's actually the case in FSHD with DUX4 that is re-expressed and shouldn't be there normally. And finally, which is also important to know, is that to inject gene therapy, we require intravenous access. So the medication is injected intravenously and has to be contained into something that can lead the gene therapy directly to the cell of the patient. And that's either viral vectors, so virus, or non-viral vectors such as lipid or nanoparticles. And here, with the medication I'm going to speak about, is basically a virus that is used. Okay, so theoretically, gene editing or gene therapy is right cutting-edge technology. It's quite fancy, etc. But of course, there are some limitations. The first one is, of course, you can imagine that injecting a virus into someone can lead to some autoimmune reaction. And this autoimmune reaction can cause a few different things. The first one is it can cause autoimmune disease such as myocarditis, so it could be life-threatening. It can, of course, reduce the activity or the efficacy of the treatment because the immune reaction can kill all the cells where the virus has been able to get in. And what is also quite important to know is that the patient that will participate to this trial with this specific virus won't never be able to be treated with the same virus again because, of course, they might suffer from a really important immune reaction the second time if the virus is injected a second time. So there are some solutions to decrease this autoimmune reaction. The first one is to use immunosuppressive drug before the injection of the drug. And that's what is actually used in EP321. And the second possibility is, of course, to restrict the access to the trial to the patient that have not been into contact to the specific virus before. What is also unknown at this moment is exactly the durability of the treatment. So we know that it's possible to inject a virus into the genome of a patient, but we don't know exactly how long this effect will remain present. And actually, the dose is also a bit difficult to define for the moment because it shouldn't be too low because otherwise there is no effect, and not too high because otherwise there is a big autoimmune reaction. So those are the limitations of gene therapy. But now let's speak about EP321 And let's start with the structure and its supposed mechanism of action. So basically, that's the structure of AP321. So it's contained into a virus, as I said, and the virus is an adeno-associated virus, RH74. And inside that, you have what we call the therapeutic cassette here, that is containing first a promoter, which is able to increase the production of the D4Z4 guide RNA. And this guide is basically the GPS of the treatment here, because it will bind or go to the D4Z4 repetition array, which is exactly where the DUX4 gene is. Then there is also a muscle-specific promoter to allow the treatment to be only active into the muscle and not being active in the liver or in the lungs or in other organs. There is also this DCAS onyx protein, which is actually really precise and can fix to the DNA exactly where we want to, and attract then a modulator or an effector, which is in this case EB2.12, which will have here the role to remethylate the area to, as I said, build a wall to prevent the gene to be re-expressed. So let me allow myself to do a little bit of an analogy with maybe it will be easier to understand. So let's imagine that you in your house, you have a leak in one of your pipe. So you will, of course, call the plumber. Here the plumber will be the drug, of course. So you call the plumber, and the plumber is coming with his truck. And actually the truck in this case is the virus, so AAV-RH74. In the truck, you will have the GPS to come to your place, and the GPS is basically the D4Z4 guide RNA. In front of your house, the plumber will need the key, of course, to get to the right house and here to the muscle and not to another organs. And this key is the muscle-specific promoter. As soon as it's inside, the repair crew leader, which is DCAS Onyx, will locate exactly where the leak is and then use his wrench to repair the leak. And that's exactly what the effector EB212 is doing. So hopefully with that, you have a more precise idea of the mechanism of action